Welcome to our presentation on our work on the prevalence of fecal incontinence and associated risk factors within a regional residential aged care facility in Australia. I'd like to acknowledge my co-collaborators, particularly Dr. Femi Afolayan, who did the data collection. My name is Rosie Crone and I'm a geriatrician. I have no affiliations to disclose and I'm non-industry funded. The study was a simple retrospective cross-sectional review of the medical records on a computerized commercial in-confidence software program. The only exclusion criteria was individual with stomas. Ethic as a consent was not required as it was low risk and it was all collected from de-identified data without interaction with the residents. And over a 4-week period, the data was analysed using a data statistical software. The statistical data is detailed in the abstract as to how it was analysed. Just a list of the data we collected. As you can see, it's pretty comprehensive with background on general incontinence, resident epidemiology, and also comorbidities as well as functional. Let's get stuck into the results. We had 107 residents, roughly equal male-female, of 78.9 years and a normal BMI, and median length of residence was 1.67 years. The majority had had fecal incontinence on admission. That's 65.1%. Over the observation period, 62.6% had fecal incontinence, but 13% of those had not had fecal incontinence on admission. Urinary incontinence was extremely common, the majority again, and everybody with fecal incontinence had urinary incontinence as well. So, there wasn't much difference between the two groups in terms of the numbers of times they opened the bowels over the 30 days. Those without fecal incontinence, 12, and with fecal incontinence, slightly more, 14. The majority, when it said constipation, had a history of constipation, but there wasn't any significant difference in those with fecal incontinence in terms of whether they had a history of constipation or not. And as you can see, the average number of fecal incontinence episodes over the 4 weeks was 7, but that fluctuated quite a lot between 2 and 14. We got some incredible data on Bristol stool form types, which is the way that the staff record on their electronic system. And what we can see here is there tends to be an increase in types 5 and 6 with fecal incontinence, and also though there was some fecal incontinence with type 4 stools, the episodes were less common in Bristol stool 4 type significantly, and also interestingly, though the numbers are probably too small to draw major conclusions, in type 6. Just to go through some resident features, there was definitely no association with increased age within this group and no gender difference. There was some association with lower weight, a significant 12 kilos, medium weight average, and the longer they were in the residence, the more likely they were to have fecal incontinence at this point of time. Yeah, the associated comorbidities were very interesting. We only found 3, those with bowel disorders, active inflammatory bowel disease and irritable bowel syndrome, which would fit in with the loose consistency causing of fecal incontinence, and interestingly with osteoporosis, my only hypothesis to explain this could be they are a frailer group than the non-fecally incontinent. There was no association with cognitive impairment or dementia or with the others, including pelvic surgery. This was the most significant slide for me as a geriatrician. We're looking at the requirement and the difficulty with initiation or prompting for toileting was the main thing, i.e. lack of awareness led to incontinence. After that, functional abilities, mainly mobility, but also ability to remove clothing, get onto the toilet, and also clean themselves. So the transferring here refers to transferring on and off toilets. Were all very significant. So, to summarize, some of the limitations were unfortunately with small numbers. We don't have medication data to see if laxatives explain the looseness of the stool and the incontinence. It's also retrospective and therefore necessarily limited. However, it's the first study for all genders in Australia in residential aged care. It's extremely comprehensive, and we did manage to demonstrate significant results in weight, consistency of stool, lack of awareness, and physical and functional dependency. Future directions, I think there is room for a prospective trial to collect data to reinforce this. A medication review would be really important. And also the therapeutic directions are stool consistency, toileting regimens, promoting physical and functional independence while looking after our residents with dignity, respect, and respecting their choices.